spectrums of the cerebrovascular disorders, including ischemic and hemorrhagic strokes. Dr. Jovin served as a principal investigator in several landmark stroke trials, including DAWN, Revascat, PAUCHE, which is a basilar artery occlusion Chinese trial, and LAST, which is another randomized controlled trial conducted in France and Spain. These trials were published in the New England Journal of Medicine and led to changes in the guidelines of managing acute stroke. Additionally, he continues to serve as a co-investigator in several local and multi-center clinical trials. Dr. Jovin has served as the president of the Society of Vascular and Interventional Neurology, as chair of the AHA International Stroke Conference, as the president of the Philadelphia Neurological Society, and several other committees or boards of national and international societies. Also as an editorial board members of several medical journals within his area of expertise, like Stroke, Journal of Neuroimaging, and Vascular and Interventional Neurology. He has published over 450 articles in peer-reviewed journals, as well as several book chapters, and he was identified in an independent peer-reviewed publication as the most prolific author in the neurointerventional field by the Altimetric criteria. We are excited for his talk today on the thrombectomy for large core stroke and why there is still a benefits. Welcome, Dr. Jovin. Thank you so much for joining us today.
Thank you very much. I'm honored to be invited, and it's a pleasure for me to talk about a subject that is very dear to me. I was hoping that these developments, the large core trial, will have made an impact that is stronger than what I'm seeing now. And I think part of that is there's still some skepticism in the community with regards to whether these results are true. It's almost like we don't want to believe what we're seeing. And one of the reasons for that is there's no good understanding for why biologically there would be benefit for reperfusion of large cores. So again, it's a pleasure for me to discuss this topic. I think it's very important, and I hope that this will sort of help us clarify a few points related to large core thrombectomy. So, and I'm going to focus this talk on really what explains the benefit. And throughout the talk, you will hear sort of statements that even in the largest of the largest cores, there is benefit from thrombectomy, and that's perhaps more difficult to understand. And I hope again that this will help clarify a few points and make us lower our thresholds, our personal, comfort thresholds to treat these patients with large infarcts. So obviously these are the 6 trials. They're very similar to it's a similar development to the 2015 landmark trials for thrombectomy, in that we have 6 trials published within a relatively narrow time window, all of them saying pretty much the same thing, except for Tesla, which was formally a negative trial, but factually very close and totally in line with all the other 5 trials. And in fact, Tesla was also positive at 1 year by formal criteria. All these trials basically showed not only benefit of thrombectomy for large patients, but benefit that is in the same range as what we've seen in small or medium size infarcts. And to me, that's kind of the puzzling. That's what I did not personally expect. And I struggled a bit making sense of it, but I think I'm sort of much more comfortable with this with this concept after giving it a lot of thought and researching the literature. So these trials have all basically used different definitions for what a large core constitutes, but there's one common element, an aspect score of maximum 5. So all of these trials used the lower limit of the infarct or upper limit of the aspects to 5. And one of them, LASTE, has basically not put any limit on the upper limit of the infarct. So unrestricted size, truly unrestricted size. Now, some of these trials have used plain CT, like Tesla intention. Others have used a combination between perfusion studies and MRI or plain CT to measure the infarct. So there's been some heterogeneity in the definition of this. Another big heterogeneity factor has been the time window. Some of these trials have used an early time window, such as Rescue Japan Limit and LASTE. Others went up to 24 hours. Others stopped at 12 hours. And also, very importantly, most of these trials have put some limits on age, either to 80 or 80 with some strings attached, with 80 and above 80, but with with smaller infarcts. So age has been an important factor here in terms of restriction of included patients. Now, again, I would like to highlight LASTE, not because I had the honor of being one of the principal investigators, but because it is the only trial that has enrolled patients with unrestricted size, infarct size. Most of the patients in LASTE were enrolled based on an MRI as the qualifying imaging criteria. That's because most of the patients were enrolled in France, where MRI is the method of choice for patient selection for thrombectomy. But about 15% of these patients were enrolled based on a CT, plain CT. These were predominantly patients enrolled in Spain. LASTE was a trial that took place in France and Spain. And the results are pretty much congruent. There's no heterogeneity of treatment effect between CT-selected patients and MRI-selected patients. So this is the distribution of aspect 0.2 versus aspect 0.3 along all, versus aspects 3 to 5 along all these trials. You will ask why there are patients with aspect 0.2 in non-LASTE trials, and the reason for that is, well, Tesla actually did allow inclusion of patients with aspects 2. They went from 2 to 5. The rest of the trials went from 3 to 5, but the ones that have aspect 0.2 in these trials are discrepancies between investigators' assessment of aspects and core lab evaluation. So what you're seeing here is core lab evaluation, and sort of that explains the fact that some of the patients that were enrolled in the non-LASTE trials did indeed have by core lab aspect scores of 0 to 2. In LASTE, which again allowed, did not put any kind of upper limit on infarct volume. The median infarct volume was 132 cc's. That's way above all the other trials. It's consistent with the inclusion criteria. And again, I think LASTE sort of proves the point in general that without a limit, that basically, regardless of the size of the core, in the early time window, and that's a very important point because LASTE limited enrollment to 7 hours from symptoms onset. That's based on the Hermes data set, showing that at 7.3 hours from symptoms onset, thrombectomy initiation, you lose statistical significance. So that's how we modeled the time window in LASTE. So in the early time window, 7 hours, there was no limit on the size of the infarct. And therefore, the median infarct volume, again, remember, most of these patients had an MRI, so we can't necessarily quibble about the accuracy of the measurement. The median infarct volume was 132 mLs. So again, here are some baseline characteristics of these patients according to trials. It's also important to mention that these trials have been conducted in Asia, Europe, and North America. So it's a very heterogeneous patient population. All of these trials basically saying the same thing. And the results basically on the MRS-03, which was the primary endpoint in some of these trials, as opposed to 02, it's been recognized that the severity of these deficits and the gravity of the problem warrants a lower threshold for a dichotomized outcome, 03 instead of 02. And pretty much, as I mentioned, as opposed, with the exception of Tesla, these results are positive. Tesla is in the same direction with an absolute risk difference of 10%, but Tesla just didn't quite make it to statistical significance, although it was very close. The rest of these trials all show statistically significant benefit. As opposed to the anterior circulation large core trials, two of these trials, tension and LASTE, also trials with with an earlier time window and larger core volumes, baseline, have shown a benefit in terms of mortality. In LASTE, the mortality, so again, the trial with the largest infarcts has shown the most impressive reduction, the largest reduction in mortality. Just looking at these numbers, the trend is towards lower mortality across all these trials. I don't know that for sure. I will show you meta-analysis, but I think that in an individual level of an individual patient level meta-analysis, I think it's very likely that we will see a statistically significant reduction in mortality. And in study level meta-analysis that has already been shown. And so there is, again, a very clear trend towards higher rates of symptomatic intracerebral hemorrhage. We know that that was basically our main concern about taking these patients to the angio suite to revascularization for thrombectomy. We were concerned that there would be an unacceptable rate of symptomatic intracerebral hemorrhages. That trend is very clear in most of these trials, if not all of them. The higher rates of symptomatic intracerebral hemorrhages were non-statistically significant, but the trend is very clear. And again, I suspect that when we put these trials together in an individual level meta-analysis, which is sorely needed and already planned and hopefully soon to be conducted, I suspect that we're going to see some statistically significant difference. But again, despite higher rates of symptomatic hemorrhage, the mortality is lower. The higher rate of symptomatic hemorrhage, I would say, is not as high as most of us expected. In LASTE, which had the most strict criteria for symptomatic hemorrhages, the rate was 9.6%, but in the control group, non-treated patient, it was 5.7%. Again, the difference is not that high, and the situation is akin to, for instance, intravenous TPA for stroke, where we know there's a higher rate of symptomatic hemorrhages, but we accept it because overall the outcomes are better and it doesn't affect mortality. So as opposed to this situation here where we have lower mortality with intravenous TPA, we have not lower mortality, we have the same mortality, better outcomes, and we accept the higher rate of symptomatic hemorrhages. I want to also clarify some of the concerns about LASTE, the prevalence of large of these giant infarcts, the aspect 0.2, and selection by MRI versus CT. In LASTE, patients were not excluded based on a large infarct. In fact, the fact that there is a disproportionate number of aspect 0.2, 56%, in LASTE, suggests to me that, which by the way, as the aspects go down at that lower end of the spectrum, the incidence is lower. So you would expect a higher incidence of aspects 3 to 5 than 0.2. In LASTE, the breakdown was more aspect 0.2 than aspects 3-5. So again, that tells me that the bias was more towards enrolling the largest core, that there was very little bias against enrolling the largest infarcts. And I just want to point out, this is a very interesting study, 158 consecutive patients studied in Germany with MRI, with DWI. These are all comers coming to a large academic center, and within 6 hours. And the investigators here have plotted the volumes of the ischemic lesion. As you can see here, the vast majority of patients presenting within 6 hours with this proximal large vessel occlusion have a small infarct. The median DWI volume was 10.2 mLs. And if we look at these large infarcts, the aspects 0.2 or not even, DWI volume of 100 cc's or more, which certainly includes probably aspect 0.2 would correspond to even larger infarcts. The percentage of these patients is only 7.5%. So it is unlikely that LASTE would have captured larger infarcts if the selection has been done by CT. There's just no patients with larger infarcts than what has been captured already in LASTE, which again had a median infarct volume of 132 mLs. So the bottom line is, once you don't put any limit to the size of the core, and you enroll all patients who qualify, it doesn't matter if you select based on MRI versus CT. The infarcts are going to be the largest infarcts, period. So I think that's why it's important to, in my mind, the importance of whether these patients were selected based on MRI versus CT, in terms of whether there's any benefit, whether the benefit applies only to MR selected patients, is misdirected, because in LASTE, all patients were selected with the largest infarcts, period, regardless of how we measured these infarcts. And this data set sort of supports this contention. The largest infarct out of 160 patients in this data set was 180 cc's. The second largest was 160 cc's. So these are definitely patients that we captured in LASTE. So again, I think it doesn't, once you don't put a limit on the size of the infarct, it doesn't matter much. And you enroll all the patients who qualify, it doesn't matter much if you select based on DW, based on MRI versus CT. The other thing that I think is very important to understand, and that's also insights from LASTE, supported by other trials as well, is that there was no heterogeneity of treatment effect, no signal whatsoever that the treatment effect is different in patients with smaller baseline infarcts within this 0 to 5 aspect score, within this median 132 mLs, which was the median DWI volume in LASTE. The treatment effects are consistent, are in the same range, regardless of the baseline infarct volume. Again, regardless of baseline aspects value, whether it's less than 2 or 3 to 5, the treatment effects do not show any heterogeneity. In fact, the point estimate in LASTE was higher for aspects 0-2 than aspects 3-5. No heterogeneity of treatment effect in patients defined by baseline NIH stroke scale score, gender, whether they received intravenous TPA or not, and age, with the caveat that in LASTE patients older than 80 were only allowed to be enrolled if they had an aspect score of 3 to 5. So age greater than 80, aspect score 0-2, we do not have any data. And again, if we look at qualifying imaging method, the point estimates are in the same direction by computer, by CT, patients selected in LASTE by CT, which were far less than patients selected by MRI. But still, over 50 patients were selected by CT. That the odds ratio is 1.34, so that's in favor of thrombectomy. It's just that it did not reach statistical significance, very likely because of the low number, without heterogeneity of treatment effect. And within the 6.5 randomization time limit, there is no heterogeneity of treatment effect by time either. Again, a surprising finding, but nonetheless clearly there is the fact that the benefit did not seem to vary according to baseline infarct volume. And the same findings were replicated among most other trials, including SELECT-2, where again, you see here by ischemic core volume, there is no difference in treatment effect. By aspect scores, no difference in treatment effect. And also very important, and that's been shown also in LASTE, we have preliminary data unpublished that again shows that just confirms the findings from SELECT-2, that if you look at mismatch volumes, presence of mismatch, whether you define it by 1.8 versus 1 or 1.2, there is no difference in treatment, there is no heterogeneity of treatment effect if you select these patients based on the presence of mismatch or not. And that has been very contentious. Again, the findings of LASTE are very in line with this. People have said, well, that's because there were very few patients without mismatch enrolled in these trials. And I think based on the graph that I showed you on the distribution of infarct volumes in the early time window, 0 to 6 hours, again, we're talking here predominantly 0 to 6 hours, although SELECT-2 was went out to 24 hours, but at least in the 0 to 6 hours, based on the distribution of infarct volumes that I showed you in the earlier slide, it is very clear that most patients have mismatch. The vast majority, based on their infarct volumes, will have some mismatch. So again, I don't think, whether mismatch or no mismatch is a treatment effect modifier, In the early time window, it's almost always there, and it's probably not worth the time expenditure to look for it, because every time we look for a mismatch, that costs us time. And to me, it's very clear that that time is not well spent, because we cannot differentiate responders from no responders based on the presence of mismatch, at least in the early time window. There's been one trial that is heavily quoted as, in Rescue Japan Limit, it's been shown that patients with aspects of 3 or less don't benefit from thrombectomy. That's actually not correct. If you look at the aspects 3 or less, the odds ratio is again in favor of thrombectomy. It's non-statistically significant. We can't say that it's not beneficial. We can only say that based on Rescue Japan Limit, there is no evidence that it's not beneficial, or we can say it's underpowered. But the point, there is no statistically significant evidence of benefit. But the point estimate is in favor of benefit with thrombectomy, even in Rescue Japan Limit. So, probably underpowered. Maybe there was no benefit, but we can't say that there is no benefit. All we can say is that Rescue Japan Limit investigators were not able to demonstrate statistically significant benefit in patients aspect 3 or less. But there is no evidence that in these patients there is no benefit. We cannot say that. As opposed to LASTE and SELECT2 and many other trials, and you'll see the meta-analysis study levels that basically refute this notion. And this is a very recent meta-analysis published in May in Neurology, basically showing once all these 6 trials are put together, if you look at MRS3, very robust, statistically significant benefit as expected, right? Because all of these studies were basically positive, except for Tesla, which was very close. Even on the ranking 0-2, once you put all these studies together, you have evidence of statistically significant benefit. And now, putting all these studies together, it's not an individual patient level meta-analysis, but still, I think when it comes to mortality, we can very likely trust these numbers. There's a 20%, not necessarily the point estimate, but the direction. And yes, we have a mortality benefit when these patients are being treated. That is not the case, by the way, with thrombectomy for patients with small or medium size score. In Hermes, there was no mortality benefit. So again, on the mortality side, there is, as opposed to Hermes, benefit. Okay, and again, in subgroup analysis, as I showed before, whether you have an aspects of less than 3 or 3 to 5, same treatment effect. Whether you got intravenous thrombolysis or not, same treatment effect. Whether you came in with an NIH stroke score less than 20 or 20, same treatment effect. Regardless of infarct size, greater than 70 or less than 70, same treatment effect. Less than 100 versus greater than 100, same treatment effect. Now, let's go to 150 cc infarct volumes. Less than 150 cc, greater than 150 cc, it's the same treatment effect. Are we going to believe these data? These are 6 randomized trials that are being put together. And yet, we are all reluctant to adopt these findings in our clinical practice. I think this time issue is still needs to be sorted out. It looks like certainly in this study level meta-analysis, there's no heterogeneity of treatment effect with respect to time. I think when we put these cases together individually, I'm very interested to see what the results are, especially in the aspect 0-2. category. And I also want to point out that something that many people have said, that, okay, you know, this is LASTE, these are the results of LASTE. And what you're doing, because on the medians, the thrombectomy group achieved a median of 4, versus in the control group, patients, the median was 6 dead, basically. Basically what you're doing is you're transforming, you're saving patients from dying, but you're transforming them into undesirable outcomes because people don't want to live with a ranking of 4. And this is incorrect from many viewpoints. One of the most important being, well, the most important being that, you know, quality of life studies and utility-weighted research have shown that most people, whether we believe it or not, but most people value a ranking of 4 more than a ranking of 6. But beside that, actually, if you look at the distribution of outcomes in LASTE, both in the ranking 0-3 and in the 3-5 and in the ranking 0-2, you will see that there's a gain in mortality, 20% less mortality in the thrombectomy versus the control group, and almost this entire 20% of the patients are found in the ranking in a higher proportion of ranking 3, not ranking 4. So these median numbers are deceiving. They just represent medians. They don't represent, they're not telling you actually how these outcomes are shifting. So if you look at how the outcomes are shifted, the shift goes from mortality to ranking 3. The numbers otherwise are staying about the same. So basically, in LASTE, what we showed is that mortality leads to reduction in mortality translates into predominantly higher numbers of ranking 3, which all of us, I think, would agree is a state that is more desirable than death. Okay, so I think that should put this issue to rest as well. So I'm sorry, this I think I already showed that. So the other, again, very important issue that I'd like to highlight is that the number needed to treat in LASTE was 4. Now, this number needed to treat of 4, let's put it into perspective, right? Let's compare it to the anterior circulation, early and late time window thrombectomy in patients with small, most of the patients in the late time window had small infarcts, or early time window where there were most patients with small and medium size infarct. What was the number needed to treat in Hermes? But by the same outcome measure, which was shift analysis, there was 2.6. So 2.6 versus 4. And in Aurora, the late time window, 6 to 24 hour thrombectomy meta-analysis, the number needed to treat was 4, the same as in LASTE. Okay, so to me, that's the big surprise of this development. Not necessarily that there's benefit, but that the magnitude of that benefit is the same. So that's really very puzzling. It has been puzzling, still is, and something that we as the stroke community, we need to sort of better understand and research, right? The treatment effect is the same. It's very, very similar, whether you have a large baseline infarct. And by the way, that's consistent with the data from these meta-analyses that I showed you. Whether you have an infarct, baseline infarct of 100, of 150, of 130 or not, the treatment effect is the same. So that the fact that the number needed to treat in Hermes, in Aurora, in the in LASTE, in these large core trials, are the same, basically is all consistent. And it sort of makes you wonder, why is that? Because if we understand why that is, we're going to lower our comfort level to actually adopt these findings in clinical practice. Okay, so how can we explain the results of these large core trials? How can we explain the fact that the number needed to treat, that the treatment effect is the same regardless of the size of the infarct? And one explanation is very obvious, right? What we see on imaging is different than the real core. We think that the patient has a large core because it's ingrained in our mind that when the DWI lesion is 150 cc's or 100 cc's or whatever, that means that the patient has a large core. But how, to me, these developments have sort of fundamentally put in doubt our ability to really to accurately measure the real amount of that brain. Okay, and by the way, all these attempts to explain these findings are very nicely summarized by our current endovascular fellow, Ahmad Balaut, in his paper in stroke, outlining this imaging neuropathological gap and trying to explain it, as you can see here, based on the theoretical model. Once you reach 100% core, there should be no benefit in terms of MRS-03. You should have the same percentage of MRS-03 or whatever clinical outcome you want to choose. Whereas in reality, what we find, there is a gap. Even at the 100% core, we still have a gap. We still have a delta. We still have a higher percentage of good outcomes in these patients who are being thrombectomized. And the question is why? So as I said, one of the reasons could be just that we're not able to accurately measure the infarct. But I will outline, and that's something that is also explained in this paper, that's not the only explanation. There are other explanations, and I think they're very nicely discussed in this paper. So again, when we talk about the fact that the core is not accurate, that's not a surprise. We know, and that's been shown time and time again, that the DWI lesion is reversible. So not everything that the DWI lesion outlines as dead is in fact dead. We know that it's reversible. And that happens in a quarter of patients with acute ischemic stroke. That's a meta-analysis published 5 years ago. And also, very importantly, the earlier the patient is in the ischemic process, the more likely it is for the ischemic lesion to reverse. So again, that sort of supports that what we think is core is in fact not core. Same with CT perfusion. We have this concept of ghost core. You measure the infarct, before thrombectomy, before reperfusion, and then on follow-up, there are areas that look like they're dead on CT perfusion, but on imaging, they're not dead. And again, that happens about 20% of patients, according to this paper from Mark Ribot's group from Barcelona. And again, just like with MRI, the earlier the patient is in time, the more likely to have this phenomenon of ghost core, just like with MRI. And now there's some reports. This is much rarer, and I must say I've seen it as well in my practice. I've seen it once or twice only, but that it has been described that true hypodensity has been found to be reversible on follow-up imaging. So, and that makes sense to me because we're imaging surrogates of death. We're not imaging a dead brain cell. We're imaging surrogate, in this case, amount of edema and amount of water uptake. And if we reperfuse the brain very fast, this surrogate is not accurate. So I think, to me, the most reliable sign of dead brain is hypodensity on CT. But just as a caveat, theoretically, not even that is 100% accurate. And why is that? Well, one of the issues is that our model of core and penumbra is oversimplified. It turns out that there's penumbra within core. Again, there's penumbra within what we represent as core based on imaging. And there's core in the penumbra, again, in our constructs of what is penumbra based on imaging. And that's a very nice paper published almost 15 years ago, explaining this phenomenon. This led to my good friend Vincent Postalat, who was one of the other PIs of LASTE, to postulate that this model of core and penumbra, and a nice representation of a core surrounded by penumbra and oligemia and all that stuff is not a realistic, that was the before LASTE, before the large core trial model. And the model that we need to have in our mind now after large core trials is that there is a mishmash, there's a mosaic of geographically intermingled cores and penumbra. And I think that the bottom line is that the imaging methods that we currently have at our disposals are just not accurate enough to tell us exactly what is reversible and what is irreversible. So that's sort of one explanation. Imaging has let us down. What is another explanation? Well, the other explanation is that there is benefit from reperfusion beyond penumbral salvage. And what is that benefit? Well, one benefit is edema reduction. And there's also not very likely, it's been shown that reperfusion has some neuroprotectant value. And we'll go into that in more detail. But let's just talk a bit about this theory that clinical benefit from reperfusion is exclusively penumbral salvage. What if there's other benefits? Well, we know that just penumbral salvage is only one of the benefits. This has been shown in mediation analysis. Mediation analysis means, what is the percentage of an observed outcome that can be attributed to an intervention. So in this case, what is the percentage of clinical benefit that can be explained by penumbral salvage? And there's been several such studies of mediation analysis, including in Hermes. And most of these studies have shown that the reperfusion and penumbral salvage only accounts for about 50% maximum of the clinical benefit that is being observed. So we, in our mind, in my mind at least, before this whole story, it was very simple. The benefit of reperfusion, the clinical benefit was 100% explained by penumbral salvage. And it turns out that if you actually look at it formally and do a mediation analysis, that's not true. Only 50%. Now, there's other factors, location of the infarct, et cetera, et cetera. That's easier to understand. But there are also other factors. And one of these factors is edema reduction. And the same group that published a mediation analysis on showing that only 50% of penumbral salvage is due to, of clinical benefit is due to penumbral salvage, has looked at large infarcts and has shown that if you do mediation analysis in this particular group of patients with large infarcts, that the bulk of benefit comes from edema reduction, which is in their case series 66%, and only 22% is mediated by penumbral salvage. Okay, and that's could be the main mechanism of benefit in these large vessel stroke. But even if you add those 66 and 22% together, you still don't come up to 100%. There's other factors as well. So this is a very interesting hypothesis and papers that it took me a long time to find in the literature. There hasn't been much research in this area, and I think we should look at it more carefully. These are Japanese investigators who have looked at reproducibly same size infarct with a minimum time of occlusion in animals. And despite the same size infarct, maximum, the infarct reached its maximum size, they kept the vessel occluded at different time intervals. So they had the same infarct produced by occlusion of 1 hour versus 3 hours versus 6 hours, whatever, or permanently. And then they kept the animals alive, and they looked at functional outcomes of these animals. And they observed that despite the same infarct size, functionally, animals that were reperfused earlier did better, okay? And these are two different Japanese centers, independent, that have reached the same conclusion, same type of experiments. And the theory is this is, as I said, a different lab reaching the same conclusion. And the explanation for that are very elegantly outlined in this beautiful paper that I recommend to everyone, showing that basically there's a benefit even after the neurons die. There's endothelial cells and pericytes that are more resistant to ischemia. They call it stage 2 reperfusion. The neurons, so stage 1 reperfusion is the penumbral theory, right? You still have neurons that are alive, and you benefit from reperfusing these neurons. But even after neurons are dead, you have pericytes and endothelial cells, and the pericytes can develop into stem cells. They promote vasculogenesis, neurogenesis, and that leads to a higher recovery potential. Again, and preservation of endothelial cells keeps the blood-brain barrier intact with beneficial effects on the recovery, okay? So what they're not saying is what happens when all these elements are dead, neural cell and endothelial cells. They call it stage 3 of ischemia. We don't know about that because imaging does not allow us to differentiate between stage 1 and stage 2. And it's possible that in stage 3, there's no benefit. It's possible there is. It's something that we need to look into. But certainly, I think that's a very nice explanation in terms of potential for recovery that reperfusion has even after the neurons are dead. So we have at Cooper, we have a neuroinflammation lab led by Dr. Khalid Hanafi, one of our neurointensivists, and we started looking at reproducing these findings of the Japanese researchers. And it's a very preliminary. It appears that reperfusion causes activation and switch from, again, reparative cells, macrophages, from inflammatory and destructive cells. So there's some, and these are preliminary findings. Look forward to sort of a more definitive data set, but just as the Japanese investigators suggested, there's neuroprotective benefits of reperfusion, even when the neurons are dead. Now, we have basically shown on the clinical side something very similar. A few years ago, we published this paper where we showed that we looked at patients who ended up with very small infarcts, less than 20 cc's, across the 0 to 24-hour thrombectomy spectrum. So everybody has the median infarct volumes were the same in early versus late reperfused patients. And all these patients were studied with MRI. And what we showed was that even though the final infarct volume was the same, earlier reperfused patients did better than late reperfused patients. So then again, suggesting that there's a lot more to clinical outcome and clinical benefits than the final infarct volume. And that's something that the meta-analysis now are showing. There's a clear, this is study level meta-analysis, the same that I showed you, published in Neurology, showing that basically just like with the small and medium vessel and medium-sized infarcts, that the benefit of reperfusion is time dependent, and in these large infarcts, the earlier you treat the patient, the more robust the clinical benefit. So these findings, I think the Society of Vascular Interventional Neurology has analyzed these data in a very objective way, and came up with guidelines that are anchored in the data. The recommendations are now that, based on the data that I showed you, that in patients in the early time window, 0 to 6 hours, and younger than 80 years old, aspect 0.5, whether by CT or MRI, thrombectomy is recommended. And that's based on LASTE and several other meta-analyses. And then in the 6 to 24 hours, aspects 3 to 5 is level 1A also. Again, this all applies to patients younger than 80 years old. And then 6 to 24 hours, aspect 0.2, I think we still need to understand better whether there's benefit or not. Now, that doesn't mean that we need to treat every patient. I think that's very important to highlight, and my views on this is what we expressed in the editorial that me and my colleagues wrote, accompanying the Tesla trial publication, where we said that these decisions should be made on individual level, and we shouldn't necessarily take every patient, and that our decision to take the patient to thrombectomy should be based on discussions with the family, while taking into account the multitude of factors, including that the likely outcome, given the best circumstances, is going to be not that good, a ranking of 3 or a ranking of 4. And that's something that families should take into account, and decide based on what the patient's presumed survival preferences are, plus many other factors. But importantly, I think this decision should not be made based on an aspect score or an infarct volume alone, because the infarct volume cannot differentiate between patients who benefit versus do not benefit. So with this, I'm going to end my talk, and happy to take any questions.
Thank you so much, Dr. Jovin, for the great talk. I will leave the floor now to our faculty for any questions or comments.
Yeah, my camera on here. Yeah, that was terrific, Tudor. As always, you lay out your arguments, and having known you a very long time, you've always been early and aggressive advocate for stroke thrombectomy and stroke patients. So this is incredibly compelling and very cogently articulated this morning. I think there is a lot of resistance to taking that 79-year-old with a low aspect score. I think that is something that the community that treats these patients has been maybe cynical about. Obviously, the data speaks volumes, and that's the strongest case for the treatment, and the number needed to treat of 4 is an amazingly low number, which is very compelling to treat this. But my experience seems to be it's easy for people to find a reasons not to treat when they don't want to treat a patient, when they're sort of feeling maybe a sense of futility that your data shows isn't justified. How do we address that?
Well, I mean, I think that guidelines will help. I'm seeing some reluctance, even in publications, to endorse what the data actually shows. That even in these aspects 0-2, there is benefit. I mean, again, that doesn't mean that we need to treat the patients. If you actually, and I think that the answer should come from respecting patients' preferences. If you have a patient with an infarct volume of 150, you can tell the family that they have a 15% chance of walking independently and a ranking 0-3. That's an 85% chance of being more severely disabled or dead. But if there's no treatment, then that chance is 0 or 5%, and let the families decide, and coach them and ask them, do you think he would, your dad or your mom would accept this kind of level of disability? And many patients say no, and then that's fine. But some would say yes, and those should be treated, I think.
And just as a real practical matter, how are you addressing the tail, the time tail? You're aggressively going up to 24 hours. Are you drawing a line at 24 hours? How are you? It's just sort of pure practical practice. How are you managing that?
Well, I mean, first of all, in the early time window, I think we shouldn't look at the core because I mean, to me, this is a very strong argument in favor of either going directly to angio or minimizing to the absolute possible, minimum possible imaging, because we're doing all these tests, these imaging studies that have no practical consequence. All we're doing is wasting time, right? We're hurting the patient by doing advanced imaging, right? Because they don't help us make a decision. So in the early time window, I would say don't even care about the core, just save time, right? Go directly to angio or just do a simple CT. You see a hyperdense MCA, go. Or, maybe if you want to do a CPA, that's fine if the patient has a very severe deficit. But the focus has to be on, to me, the biggest consequence of these large core findings is that we have to minimize imaging in the early time window. Because if, as I showed, the number of patients with these giant infarcts is minuscule. We're wasting time to find 5% of the patients, and the rest of the 95, we take another 15 minutes or whatever it is to do a CT perfusion or an MRI when in fact it doesn't matter, right? So in the early time window, don't image because you're hurting the patient by imaging the patient, advanced imaging. In the late window, I don't know yet. I think aspects 3-5, probably, infarcts 100 mLs. And again, the data that we have, even in the large infarcts beyond 6 hours, is not that we're hurting patients. It's just that we don't know whether we help them. So, if you make the decision to treat the patient, you're not going to hurt the patient. It's just only an inconvenience and a resource issue. It's not that you're hurting the patient by treating them. So I think that aspects 3-5 should be treated. That's what the data shows. Again, keeping in mind patients' preferences. If they don't want to live with a ranking of 3, don't treat them, okay? But don't refuse the treatment just because they have an aspects 3. Now, aspects 2 in the 6 to 24 hours, I think that's something that we need to further explore and hopefully trial. And hopefully we'll get an answer. What I do in my practice is, if the patient is young, I give them the benefit of the doubt, and I go. And this is a neurosurgery centered talk. I would love to see us, and I hope we're talking amongst ourselves. I would love to see a trial where we take patients to with these giant infarcts, very large, 130 or above or something like that, to thrombectomy and then hemicraniectomy right away to mitigate the
edema.
Yeah. So because it seems to me that there are some benefits of reperfusion that we haven't thought about, and so why not in young patients? Again, young patients. So right now, as these giant infarcts, which are actually more common in the 6 to 24 hour time window, my inclination is to treat them just like hemicraniectomy. Talk to families, offer it predominantly, to families, to patients who are younger. And be ready to do a hemicraniectomy, have a low threshold for it in these younger patients. I intuitively, yes, I don't think that 79-year-olds with an aspect of 2, I think we're hitting a plateau there in terms of what benefit we can derive, because I don't think there's many who do well and who achieve a state that they would be happy with in terms of their quality of life.
Yeah, and then that's the other boundary of time is the age, and of course these trials were predominantly 80, 85 and under.
Yeah.
Obviously, it's a harder decision when you get those over 85.
But it's a moving target, and I'm hoping that there will be neuroprotectant approaches that will improve outcomes. I'm hoping more. I have great hope from neuromodulation, VNS stimulation, and we've had some of our patients who benefited. I mean, I've seen it firsthand, the benefit. So, save as much brain as you can, and in the future there may also be other approaches that have to do with recovery that would make these patients' lives better.
I think the other thing that we need to sort of keep in mind and is really highlighted in all of these trials that you showed us today is how safely we're doing the procedure. So it's certainly a resource allocation problem. It is costly to keep a team doing thrombectomies at a center and to have the number of centers to manage this case volumes. But by and large, we're not causing a lot of complications and a lot of harm. So the downside of the procedure is relatively minimal compared to the potential upside. And so I think
again, I think we need to keep in mind that these are very few patients. Again, if you look at the percentage of patients with infarcts greater than 80 in the 0 to 6 hour window is 12%. Okay.
Right.
So even if we treat all the patients, we're going to treat 10% more. I mean, I think 100 now is kind of the universally accepted cutoff, right? So 100 is 8% of patients, right? So if we treat everybody, we're going to only treat 8% more patients. We're going to treat them faster if we don't care about the size of the implant.
Yeah, that's an excellent point, because I think a lot of us are sort of worried about the floodgates being open and just being expected to treat every patient that walks through the door.
Yeah,
I think that is an important thing to keep in mind.
Yeah, in the 6 to 24-hour time window, I think there's a lot more. And yes, that resources become an issue. But in the early time window, there's just not that many patients with giant infarcts.
Steve, I'm not sure if you're online there. Are you any comments?
Yeah, thanks again, Tudor. That was great. I would just sort of echo Cameron's comments that even though the data is in front of us, I think particularly for the dominant hemisphere, large strokes and elderly patients, the enthusiasm from both neurology and the neurointerventionalist kind of flies in the face of the data, and I wonder where that point of equipoise is. How big a delta would we have to see, before people would make the decision to be enthusiastic about taking these patients? I guess my question is, with this concept of MRS shift, and you touched on it nicely, going from an MRS of 6 to an MRS of 3 is significant. But do you think the MRS shift method is an appropriate way of determining whether we're helping these folks? Is that sort of the best way of determining a sort of a functional or useful positive outcome?
Well, I mean, that's a great question, and but we know that from population surveys. I mean, at the end, it's a good outcome is an outcome that the patient is satisfied with and feels it's better than the alternative, right? And as I mentioned, an MRS3 is valued if you do quality of life measurements in the population, surveys and things like that, is valued more than being dead. So that's all I can tell you. There's also all these trials have quality of life assessments, and the quality of life assessments are all in the positive direction. So in terms of treated versus non-treated patients. So important questions, especially in the elderly patients. That's why I think in the elderly patients, things look very differently, or are likely to look differently. But all the information that we have right now, the data that we currently have, points toward the fact that from a patient's perspective, it is preferable, in younger patients to have the procedure than to die.
Good point. I'm curious if you could expand upon the early decompressive hemicranie, sort of immediately after a thrombectomy. We see sort of variable swelling due to collaterals and that sort of thing, and obviously dominant hemisphere versus non-dominant hemisphere. What sort of treatment paradigm or kind of trial setup would you envisage that working? You do a thrombectomy in a hybrid room and then just take the bone off right there? Is that the idea? Or
well, that would be great if you have the setup, but I don't think the urgency should be that to that degree. I mean, you can do it, a few hours, within a few hours. The way I envision, I think we should do a trial, and if you guys are interested, it would be great to collaborate. The way I envision is you do the thrombectomy in a patient with a large core, you make sure that the family is on board with an aggressive treatment course, because if they want to withdraw care, there's no point, right? Do they want a hemicraniectomy up, to begin with? Do they want to be aggressive? And after the thrombectomy, you measure the infarct. If it's 130 or greater, I'm picking a number, 125, we can all agree on a number. Then you either go immediate hemicraniectomy, meaning within an hour or 2 or 3 or whatever, maximum 6 hours, I would say, versus standard of care, which includes a hemicraniectomy when the patient gets worse, or by whatever criteria that particular center uses. Because the idea is that some of these patients do develop malignant edema that is related to reperfusion, and the idea is to harness the benefits of reperfusion that I hope I kind of made a case for, that are beyond penumbral salvage, but also prevent the deleterious effects of reperfusion.
Interesting. Yeah, we'd be interested.
Young patients mainly, the typical candidates for hemicraniectomy. If the patient's old and the family doesn't want a hemicraniectomy, or we don't think the outcomes are going to be good, then it's not a good candidate for such a trial.
Yeah, younger patients, big swollen brains, that sort of thing.
Yeah, or potential for big swollen brains. You don't wait. You don't
gotta be ahead of the curve.
Yeah, exactly.
Yeah. Well, thanks again, Tudor. Really enjoyed the kind of the summary, and very challenging, I think, for all of us to look at these cases, and we'll be thinking about the summary that you've presented for us as we're identifying individual cases. It's certainly plenty of food for thought.
Yeah, I think that there's some of the reluctance comes from the fact that we don't intuitively, we understand the data, we see the data, but we don't believe it because it doesn't fit with our pathophysiological model. And what I try to do is, provide some reassurance that there is some, reasons to believe these data.
Yeah, beautifully presented, and again, data that changes our world, changes our practice, and helps patients. So really appreciate it. Appreciate all your work always, and always great seeing you. Thanks so much for being with us this morning.
Thanks a lot for having me. Appreciate it. Thank you.
Thank you.
Bye now.